So probably the number one problem, can I have the clicker? The number one problem in hip arthroplasty today, you know, I've seen the enemy and it is us. It's acetabular component positioning. So there's two challenges: determining the target for that patient and hitting the target. So you can talk about socket position, which is medialize the center of rotation, and containment of the shell, and socket orientation. I like to shoot for a lateral opening angle that's 40 degrees plus or minus 10, and a combined anteversion, that's the femur plus the socket, of 30 degrees plus or minus 10. I assess the femoral version and place the cup in a complementary position to get the best femoral acetabular mating. So this slide's been shown all over the place. The community standard is probably a little bit broader than what the MGH guys put as their target. They said the acceptable range of abduction was 30 to 45 degrees in version 5 to 25, and they hit that 50% of the time. The increased risk of malpositioning was associated with these variables: an MIS approach, lower volume surgeons, and obese patients. So Bill went over this. It's worth reemphasizing. I do pre-op planning on every case, and I do it myself. I consider this part of the instrumentation of the hip. So I put the acetabular component on first. I overlay the femur. I want to look for containment. There's my medial wall. There's my lateral lip. There's my center of rotation. I'm shooting for 45 degrees lateral opening on my templating. That's my femoral neck cut. I put the stem in to get the limb length and offset right, and that's the post-op x-ray on that case. That's a 28 head, by the way. So this is what I mean by trying to get complementary version. So I do the femur, and I'm looking at that. Now this guy doesn't have a whole lot of version in his proximal femur. Now I'm going to try and cut a little bit of version into that, but I want to know what it is, and I'm going to take that forward. So if somebody doesn't have much version, anaversion, in their femur, I'm going to put a little more anaversion in their cup, and vice versa. You got this plastic hip that's got 20, 30 degrees of anaversion. I'm going to put less version in their socket. So get exposure. You know, there's a lot of sneak in, sneak out kind of stuff, but if you want to get the acetabular component right, you got to get some exposure. And one of the biggest reasons why cups go in vertical is because your incision is too proximal and you can't get the handle of the inserter down low enough to get that correct angle of attack. I use internal references: the medial wall, the lateral lip, the anterior lip, and sometimes the transverse acetabular ligament, although I don't use that as a sole or absolute guide. I use external landmarks: the patient axis and the inserter handle. Always do a trial range of motion. Does it all add up? And when it doesn't add up, get an x-ray. I have a very low threshold for getting an intraoperative x-ray. One of the things that I think has sort of revolutionized orthopedic surgery is digital intraoperative x-ray. What you see is what you get. It's better than navigation. It's better than virtual reality. Get a digital intraoperative x-ray. This is the anaversion thing again. We showed that slide once before. Know how to get this picture. You can assess what the version is of, on the cup. You don't need any fancy instruments to do that.